All right, welcome to another deep dive, everybody. Today we're going to be looking at ICD-10 guidelines,
Okay.
specifically for nervous system conditions and pain.
Right.
And we're going to be focusing on how those relate to chronic pain,
Okay.
neoplasm-related pain,
Uh-huh.
post-operative pain,
All right.
and pain due to devices, implants, and grafts.
Okay.
Now, to help us navigate this, we have the Absolute Medical Coding Institute's Medical Coding Guidelines MCG Manual,
Right.
or the FLIP for short. It's linked in the description if you want to follow along.
Okay.
Now, these codes might seem like just a technicality,
Right.
but they actually have a huge impact on how healthcare is documented, billed, and ultimately the care that you receive.
Yeah, for sure.
So to help us decode this world, we have with us an expert in all things ICD-10.
Happy to be here. I'm always fascinated by how these seemingly small details can have such significant ripple effects throughout the healthcare system.
Yeah, it's kind of like a secret language that dictates so much behind the scenes.
Exactly, yeah.
And one of the first things that caught my eye was this idea of dominant versus non-dominant sides.
Uh-huh.
I thought it was just about being right or left-handed,
Right.
but it's actually way more complicated than that, isn't it?
It is, yeah. It plays a crucial role when you're coding for conditions that affect one side of the body.
Okay.
Like hemiplegia, which is paralysis on one side, or monoplegia, which affects a single limb.
Right.
The codes require you to specify whether the dominant or non-dominant side is affected.
So even if someone is ambidextrous, the coding still defaults to dominant.
Yes.
Why is that?
It might seem counterintuitive,
Right.
but the guidelines, they operate on this principle that the dominant side generally has a greater impact on a person's overall function. So even if someone is equally skilled with both hands, the dominant side is given priority in the coding.
That's really interesting. I never would have thought of it that way.
Hmm.
But I can see how this could easily lead to errors if the documentation isn't super specific.
Absolutely.
Yeah.
Just imagine the potential implications if a patient's dominant side is affected.
Right.
But the coding incorrectly reflects the non-dominant side.
Yeah.
It could impact everything from insurance claims to treatment plans.
Right.
It's really important.
It really underscores the importance of precision in medical documentation. Every detail matters.
Yes, absolutely.
Now let's talk about another coding concept that seems a bit paradoxical, the G89 code. It's for pain, but sometimes it's not used for pain even when pain is present.
Yeah, that's right.
So how does that work?
The key here is understanding when a G89 code is appropriate. It comes down to the primary reason for the patient's visit.
Okay.
If the focus is on managing the pain itself,
Right.
then G89 is often used.
Okay.
But if the focus is on treating the underlying condition that's causing the pain, then G89 might not be necessary.
So it's not just about the presence of pain, it's about the context of the visit.
Exactly.
Okay, could you give us an example to illustrate that?
Sure. Let's say someone comes in with chronic back pain due to a herniated disc,
Okay.
and they're getting a steroid injection to manage the pain.
Okay.
In this case, the G89 code for pain would come first,
Okay.
because the immediate goal is pain relief.
Gotcha.
But let's say that same patient is admitted for surgery to repair the herniated disc.
Okay.
In this case, the code for the herniated disc would come first because the surgery is addressing the root cause of the pain.
So even though the patient is experiencing pain in both scenarios,
Yes.
the coding changes based on the primary reason for the encounter.
Exactly.
That's fascinating.
It highlights how these codes are more than just labels. They tell a story about the patient's condition and the focus of their care.
Right. Speaking of chronic pain, I think a lot of people associate that term with pain lasting for a specific length of time, like 3 months or more.
Yeah.
But our sources tell us there's no set time frame.
That's correct. The guidelines emphasize that it's the provider's clinical judgment that matters.
Okay.
If the provider determines that the pain is persistent and ongoing, regardless of the duration, it can be coded as chronic.
So it really comes down to the physician's assessment of the patient's experience.
Exactly. And within the G89 category, there are specific codes for different types of chronic pain.
Okay.
For example, chronic pain itself is G89.2,
Okay.
but then you have codes like essential pain syndrome, G89.0, and chronic pain syndrome, G89.4.
Those sound pretty similar. What's the difference?
So chronic pain, G89.2, is a broader category encompassing any persistent pain.
Right.
But central pain syndrome and chronic pain syndrome are distinct diagnoses with specific criteria that need to be documented by the provider.
So a physician can't just write chronic pain on the chart and expect it to be coded as G89.0 or G89.4.
Right.
They need to be more precise in their documentation.
That's right. To use those specific codes, the provider needs to explicitly document that the patient meets the criteria for either central pain syndrome, which often involves damage to the central nervous system,
Right.
or chronic pain syndrome, which often involves a more complex interplay of physical, psychological, and social factors.
It seems like those details are really important for ensuring the patient's condition is accurately reflected
Yes.
and ultimately treated appropriately.
Mhm.
Now let's shift gears and talk about another specific type of pain, neoplasm-related pain.
Okay.
So this refers to pain that's associated with cancer, which unfortunately is a common and often debilitating symptom for individuals with neoplasms.
Yes, it is.
And there's a specific code for that, G89.3, right?
Yes, G89.3 is used to capture neoplasm-related pain, whether it's acute or chronic. Now, when it comes to sequencing,
Okay.
if the encounter is primarily for pain management, then G89.3 comes first, followed by the code for the underlying neoplasm.
So similar to our earlier examples,
Yeah.
it's about prioritizing the reason for the visit.
Exactly. But if the encounter is primarily focused on managing the neoplasm itself, let's say the patient is receiving chemotherapy, then the neoplasm code comes first, and G89.3 is listed as an additional diagnosis.
It seems like the purpose of the visit is a key factor in determining the order of the codes.
It is. It's all about capturing the full picture of why the patient is seeking care
Right.
and what the focus of that care is.
This is all so insightful. I'm starting to see how these codes really do tell a story. And speaking of stories, let's talk about post-operative pain, pain that occurs after surgery.
Okay.
I'm curious about how that's coded because I would assume pain is a pretty common experience after surgery.
You'd be right, but the guidelines make a distinction between routine, expected pain that occurs immediately after surgery
Okay.
and pain that goes beyond what's considered normal.
So if I have a knee replacement and my knee hurts for the first few days after surgery,
Yes.
that's not necessarily something that would be coded?
Exactly. That's considered a normal part of the recovery process. It's only when the pain is excessive, prolonged, or doesn't respond to typical pain management strategies that it would be coded.
So it's about distinguishing between expected discomfort and pain that's outside the norm.
That's right.
Okay. And if the documentation doesn't specify whether the postoperative pain is acute or chronic, it defaults to acute.
It defaults to acute.
Interesting. So what happens if there are complications? Does that change the coding?
Absolutely. If the postoperative pain is related to a complication,
Okay.
like an infection or a problem with the surgical wound,
Right.
then we would use codes from Chapter 19 of the ICD-10-CM Manual
Okay.
to capture those specific complications. And we might also add a G89 code
Okay.
to specify whether the pain is acute or chronic.
So you could potentially end up with multiple codes for a single instance of postoperative pain depending on the circumstances.
That's right. It's all about accurately representing the complexity of the situation and ensuring that every aspect of the patient's condition is properly documented.
This has been so enlightening. I'm really starting to see how these codes play a crucial role in painting a comprehensive picture of a patient's health. But before we go any further, I think we need to take a pause. When we come back, we'll delve deeper into the nuances of pain due to devices, implants, and grafts.
That's good. So before the break, we were talking about postoperative pain
Right.
and how, pain is so prevalent and how
Right.
you code it and all that.
Yeah, and it's fascinating how, something that seems so obvious like, oh, I had surgery, of course I'm in pain,
Yeah.
might not actually get coded.
Exactly. Yeah. It has to go above and beyond the normal,
Yeah.
the expected.
Yeah, that makes sense. Now let's move on and talk about pain due to devices, implants, and grafts.
Okay.
That seems like an area where things could get really tricky.
It is. Yeah, because you have to consider, is the pain due to the device functioning as intended, or is it due to a complication?
Right.
So that's where it can get, a little bit of detective work sometimes.
So for example, if someone has a hip replacement
Right.
and they're experiencing pain during normal activity,
Yeah,
that might not necessarily be coded as a problem.
that's right.
Right.
If the pain is kind of within the expected range
Right.
for that type of device,
Right.
and there's no indication of a complication,
Right.
it might not be coded.
Okay.
But if the pain is excessive,
Uh-huh.
Or if there's a sign that the device isn't functioning properly,
Right.
then that's a different story.
So it's about determining whether the pain is a normal consequence of having the device, or if it's a sign of something more serious.
Precisely. And if we determine that the pain is indeed due to the device itself,
Right.
then the ICD-10 guidelines have a specific section for that.
Okay, what kind of codes are we talking about here?
It can involve a combination of codes,
Okay.
depending on, the location and nature of the pain.
Right.
You might use a code from the pain category, G89,
Okay.
along with a code that specifies the type of device and the anatomical site.
So if someone has a spinal cord stimulator that's causing pain in their back, you need to code for both the pain and the fact that it's related to the stimulator.
Exactly.
Okay.
And the sequencing of those codes can vary.
Okay.
If the encounter is primarily focused on managing the pain caused by the device,
Right.
the G89 cuts might come first.
Okay.
But if the primary focus is on managing the device itself,
Right.
like adjusting the settings of the stimulator,
Yeah.
then the device-related code would come first.
So once again, the purpose of the visit is key in determining how the codes are sequenced.
It always comes back to that. It's not just about, what's happening in the patient's body. It's
Right.
about understanding the context of their care.
This is all so nuanced. I'm realizing that there's a lot more to pain coding than meets the eye.
Absolutely. And it's not just about, getting the codes right for the sake of billing or documentation.
Right.
It's about ensuring that the patient's experience is accurately represented
Right.
and that their care is tailored to their specific needs.
Makes perfect sense. Now, before we wrap up, I wanted to touch on something we mentioned earlier, the TAP method.
Okay.
You described it as a helpful technique,
Yes.
especially when using the MCG manual, which is linked in the description for our listeners.
Yes.
Can you refresh our memory on how that works?
Of course, the TAP method is just a simple way to, stay organized and ensure you're applying the guidelines correctly. It stands for tab, annotate, place.
Okay, so walk us through those steps.
All right, so first, tab refers to the specific page in the ICD-10 manual where the relevant code is located.
Okay.
Then, annotate means highlighting or making notes about the specific guidelines that apply to that code.
Okay.
And finally, place means writing the word TAP next to the code itself, as a visual reminder that you've consulted the guidelines and applied them appropriately.
So it's like a little checklist to make sure you've covered all your bases.
Exactly. It helps you stay on track, avoid errors, and ensure consistency in your coding.
I love that. It's a simple but effective strategy. Now, we've covered a lot of ground today, from the nuances of dominant versus non-dominant sides to the complexities of pain due to devices, implants, and grafts. It's clear that accurate pain coding is essential for ensuring that patients receive the appropriate care and that healthcare data is reliable and meaningful.
I couldn't agree more. These codes might seem like a small detail, but they play a huge role in the bigger picture of healthcare.
Absolutely. Well, we're going to take a quick break. When we come back, we're going to wrap up this deep dive into pain coding.
Welcome back to the deep dive. So we've been talking all about pain coding.
We have.
And I wanted to circle back to something we talked about earlier, chronic pain.
Okay.
Because it affects so many people.
It does.
And I think there are a lot of misconceptions surrounding it.
Yeah, there are. So when it comes to coding chronic pain, it's not just about using that general chronic pain code, G89.2, right?
Right.
There are other codes that might come into play depending on the specific type of chronic pain the patient has.
Exactly.
So we talked about central pain syndrome, G89.0.
Right.
And chronic pain syndrome, G90.4. These codes require specific documentation from the provider to support that diagnosis.
They do.
So it's not enough to just say, oh, this patient has chronic pain.
Right.
The physician needs to provide detailed information about the nature of the pain, any associated factors, really paint a clear picture.
Yes, absolutely. The more specific the documentation is, the more accurately the patient's condition can be reflected in the coding, which ultimately, leads to better care, more targeted treatment.
And that brings us back to the importance of clear communication between healthcare providers and coding professionals.
Absolutely. Everyone involved in a patient's care needs to be on the same page.
Yeah.
And that starts with, accurate and detailed documentation.
It's like a chain reaction.
It is.
Accurate documentation leads to accurate coding, which leads to appropriate treatment, which ultimately leads to better outcomes for the patient.
Exactly. Well said. It's all interconnected.
This has been an incredible deep dive into the world of ICD-10 pain coding. I feel like I've gained a whole new understanding of how these codes work and why they matter.
That's great. I'm glad to hear that. It's a topic that often gets overlooked, but it's so crucial to ensuring the quality and efficiency of our healthcare system.
Absolutely. And to our listeners, we hope you found this exploration as enlightening as we have. Remember, these codes are more than just numbers. They represent real people and real health challenges. And by understanding how they work, we can all contribute to a more informed and compassionate healthcare system.
Absolutely.
Thanks again for joining us on the deep dive. And as always, keep exploring, keep learning, and keep diving deep.